And if you look at dose ratio studies, methadone appears to be relatively more potent at higher doses. So basically what that means is the higher the dosing that you've got the patient on, so if you're looking at conversions, then if you've got a patient who's on greater than 300 milligrams of morphine or oral morphine equivalents per day, then the conversion is usually about 10 to 1. But for lower doses, it can be as low as 3 to 1. So there's a table that was developed by an Italian guy called Stefano Mercadante, and basically he sort of said, up to 90 milligrams use a 3 to 1 conversion, 90 to 300 use, I think it was a 5 or 6 to 1 conversion, and if it's over 300 use a 10 to 1 conversion. I'm much more conservative than that, and my conversion is usually about 10 to 1 for any dose. I mean, obviously, when there's patients are on smaller doses, I'm much happier to go on the upside rather than the downside. But some of the studies that have been done looking at the dose ratio, in one study alone, the range was 2 points. So this is converting, this is from morphine, remember, and methadone. One study alone, the range was 2.5 to 1 up to 14.3 to 1. So that's once again, that's a big ratio, isn't it, of converting. So if you've got someone on, say, 200 milligrams of morphine, do you divide by 2.5 or do you divide by 14.3? The median was about 7. Another study had a median of 11. So as I say, my practice is I'm usually conservative, so I usually use about a 10 to 1 conversion. And the thing is that, and this is an important thing just to reiterate again, is to just review the patient after they've started on the drug. It's rare that we actually do total conversions. I mean, often what we'll do is do a down titrate and start someone on methadone. So maybe half the opioid that the patient's actually taking, like might be morphine or oxycodone. So bring that down by 50%. Calculate what 50% of that is and give it as methadone, and just see what happens over the next 24 to 48 hours. How often do you give methadone? Well, that's a debatable question as well. I mean, I usually start off giving the drug, calculate the dose and split the dose to give it twice a day. And then often you will find that doesn't quite last the 12 hours. Sometimes it does, but sometimes it doesn't. And then you can give, once again, recalculate the dose and give it 8th hourly rather than 12th hourly. So methadone's still available in parenteral form, and there was some fuss, quite a few years ago, that they were actually going to take the parenteral form of methadone away, and it wasn't going to be manufactured anymore. That didn't happen. At Memorial Sloan Kettering, there was an article written about how important they felt parenteral methadone actually was for those very significant and difficult pain problems. Parenteral infusions of methadone may not be well tolerated by the skin. So we don't tend to put methadone in infusions, although we do occasionally. We certainly give it via the subcut route. And the more I read about it, the more a lot of other units have no problems with the drug subcutaneously. So certainly you can use it or you can try it subcutaneously. And it could also be given sublingually, which I've never used it via that route. And there's more interest in methadone, not just because it's a mu agonist, but also its effect on NMDA receptors. So it's an NMDA antagonist, and there was a recent randomized clinical trial in non-malignant neuropathic pains showing improvement on 20 milligrams of methadone a day that wasn't seen with lower doses. Buprenorphine is Norspan. Used to be Temgesic is the oral or rather sublingual preparation. So it's a partial mu agonist, kappa antagonist and delta agonist. It's not given orally because of extensive first pass issues. It's well absorbed sublingually. Half-life's fairly short. Duration of effect 6+ hours, but Temgesic, which is the sublingual form, is not used in cancer pain. The transdermal preparation that you're probably much more familiar than I am with because it's used for non-malignant chronic pain. That particular patch, the Norspan patch, is a 7-day patch available in those dosages there, 5, 10 and 20. The 20 microgram is equal to somewhere between 35 to 50 of oral morphine per day. So it's a reasonably potent patch, the 20 milligram. The 5 milligrams, obviously, going to be a much smaller dose, around 10 milligrams or so of oral morphine. The Norspan patch has not been evaluated in cancer pain, but I do see patients who are on the drug. If someone's on Norspan and their pain's controlled, I'm not gonna stop their patch. Opioid naive patients should be started on the lower strength. And in Europe, they use a 3-day patch, which is similar to the Duragesic patch, and that's widely used for cancer-related pain. Just to briefly mention ketamine in one slide. Ketamine is an interesting drug, and there's actually a study that's going on at present in Australia looking at the use of ketamine. Because there are people who think ketamine works and people who think ketamine doesn't work, and they talk about burst ketamine and ongoing ketamine, regular ketamine, ketamine in syringe drivers using ketamine orally. And so, the jury is still out with ketamine. We found it useful in some patients. Certainly you can use it in combination with morphine. I've used it both subcutaneously and orally for patients. This concept of burst ketamine has been published in Australia. A group in Melbourne published that, looking at trying to reset to modify this wind-up system that patients get with severe cancer-related pain. So it's just to mention that ketamine is around, and you might see a patient occasionally who might go home who's got very difficult pain who might be on ketamine. So we've talked about opioid rotation or opioid swap quite a bit. The important thing to remember is that the conversions are not exact, but you've got to be in the sort of ballpark figure, and you don't want to, as I've already alluded to tonight, you don't want to give a potent opioid at the same dose as a far less potent opioid. You'll run into trouble. There are standard conversion tables that are around, and most of the drug companies are happy to give these out. You have to be reasonably confident that the doses that you're going to give are going to do the job, though, because you don't want to swap someone from A to B and then give them a third of the dose. You want to be reasonably confident that they'll get an adequate dose. Side effects. If side effects are the issue, you need to be confident the opioid is the underlying cause, which is often difficult. So morphine often gets blamed for a lot of things. So if someone's on morphine and they have a hallucination, then it's the morphine. If they have a nightmare, it's the morphine that causes it. If they have myoclonus, it's the morphine that causes it. It often is, I suppose, but it may not always be. And so, sometimes it's better to wait a little, perhaps try and treat the side effect if you can. But I guess these days often it's because we've got the choice, it's easier to swap them to something else. I don't know if everyone's familiar with this concept of opioid hyperalgesia, or this so-called paradoxical pain that can be caused by opioids. So the patient actually gets pain from the opioids. So they get signs usually of CNS toxicity, so drowsiness and flap, and they get allodynia. So, you move their limbs and they get pain everywhere. And the classic scenario is in the setting of rapid increase in opioid doses. And although it's been described mostly with morphine, it's not just morphine that this can happen with. So it's just, once again, something to be aware of. We had a patient last week who we swapped over from oral morphine to a pump at exactly the same dose. So just to swap. Why? Because she couldn't swallow the tablets anymore. And then, within 24 hours or so, she started to get pain all over the place, and I wasn't sure what was going on. And I actually swapped her to hydromorphone. It didn't make any difference. And then she died very soon after that. But it's just something, that you have in the back of your mind. But this usually happens with subcutaneous morphine and high doses of it. So once again, it's probably not something that you normally going to see in general practice. But if someone was on hundreds of milligrams of morphine, it certainly is something that might happen.